The first session is going to be dealing with tendons of the shoulder, and I will spend the first hour and 15 minutes talking about tendons in general and then talking specifically about the tendons that comprise the rotator cuff. Before we get to the rotator cuff, however, I think it's important to understand a little bit of the terminology and structure of tendons because it's pretty similar throughout the human body. So what occurs in the shoulder is also what occurs elsewhere. When I was in medical school early on, perhaps in my first year, I came across a diagram that looked very much like this, so I decided to construct one on my own. And as you look at it, we can start here because it's a very simplistic diagram of the arrangement of a muscle, tendon, and bone. I will tell you later on, we're going to indicate that this is not actually correct for many different sites, and we're going to change this drawing to something else, but we're going to do that later on. So as you see here, I've illustrated in red a tendon, a single tendon entering a single muscle belly at the proximal myotendinous junction. And as you follow this out to the right, you can see I'm illustrating only a single tendon leaving that single muscle belly at the distal myotendinous junction. That tendon will proceed to a bone and attach to the bone, and that particular area goes by a variety of names: footprint, enthesis, enthesial organ, and some of my associates call it a foot plate. But if you go and look up foot plate on your computer, you'll see pictures of trains and nothing to do with tendons. So I tend to call it a footprint. It's part of an enthesis, and we'll go on and explain that later on. Tendons, when normal, are typically smooth, and in color, they are white. And as you can see here, they connect the muscle to the bone, and because of that, they actually provide and allow for controlled joint motion. They're incredibly strong, these tendons. They're stronger than muscles, certainly, and it's said they have half the tensile strength of steel. So clearly, very, very strong structures. Now, if you want to know about the building blocks, I'm going to use this particular drawing I made years ago to indicate, like many structures, that start small and the elements of that structure get bigger and bigger. In yellow are the subfibrils, the smallest unit, and you can see I've collected them into a dark green structure, which would be a collagen fiber. Those fibers here are connected or contained within a larger structure shown in light blue. We're going to call that a collagen bundle. It will become your friend during this particular course. And those collagen bundles are arranged here on your right here in a tendon, which I'm illustrating with the red color. So these are the building blocks of the collagen that compose a tendon. Now herein lies the problem, and the problem is one of terminology. The terminology used by anatomists, by orthopedic surgeons, by rheumatologists, and by podiatrists is not the same. And so it becomes difficult when you're trying to indicate the proper name for a disorder of some structure within the tendon. What are you going to call it? What I'm going to show you now is the generally accepted terminology by anatomists. And the first term is endotenon. Note there's no D in that, T-E-N-O-N. The endotenon is shown here in this dark blue, and you can see that it surrounds the individual fascicles or bundles of collagen and helps bind them together. This then is the endotenon. The second term, epitenon, shown by the light green in my drawing now, again no D in the word tenon. This is applied to the outer surface of the tendon and is connected to the endotenon. I'm showing that with these little green stripes here that you can appreciate in the drawing. We're not done yet. We now have another structure known as the paratenon, no D, paratenon. It's sometimes applied to the outside of the tendon attached to the epitenon and consists of mainly areolar tissue or fatty tissue. And then finally, to confuse us all, another term that you will come across in the literature, a peritendon. It's a term sometimes used to describe the combination of two other things, the epitenon and the Paratina. Don't blame me for these names, all right? These are names that are in anatomy books, and they're going to influence the way you describe pathology. For example, Paratendinitis, or the term I use, Paratinonitis, is the proper term to describe inflammation of a paratinon. Now, where do we see paratinons? Typically, we see them in two particular sites, the Achilles tendon, no tendon sheath there, and the patellar tendon. And so there's a lining there, a paratinon, which may become inflamed. It can be extremely painful. This is a beautiful example on your left of what Achilles Paratinonitis looks like. And one of the interesting aspects of it, typically it is U-shaped and does not cover the anterior surface of that Achilles tendon. So this is a classic example of the shape of the distended paratinon. This is an inflammatory condition. Paratendinitis is the proper term that should be used when you see inflammation about the peritendon or paratinon. And I show you a classic example in a runner involving the Achilles tendon occupying a portion of the pre-Achilles fat pad. So this is next to the tendon, hence the term peri is really not a good term. It's para, it's next to. The proper term is paratendinitis. And this is extremely painful. If any of you have had this condition, you would know it. It is a painful condition. Now, just to finish our nomenclature here, let's move on to the term tendon sheath. A tendon sheath is composed of two things, an outer fibrous sheath and an inner synovial sheath. And there are thin connections or vincula, I'm showing you that here, that allows passage of arteries, of nerves, of veins to supply the tendon. So this is the tendon sheath. Now, of course, when we see inflammation of a tendon sheath, we've got to have a term for it. And there are two terms that are utilized. The first one is simple Tenocynovitis. And this deals with generally most of the inflammation that we see. We see fluid around the inflamed tendon. The tendon sheath itself histologically is inflamed. And so this would be called Tenocynovitis, showing it here involving the first dorsal extensor compartment of the wrist, dequer veins, Tenocynovitis. But there's another form that's more significant. And you should know this term. The term is stenosing Tenosynovitis. And actually another term for that is tenovaginitis, all right? So that is a term you will come across. This is more significant because in addition to inflammation, there are adhesions between the tendon sheath and the tendon. And so the tendon does not move properly within the tendon sheath. We see this in various locations. For example, often with dequer veins, it is a stenosing Tenosynovitis that is present. In this example, I show you perineal stenosing Tenosynovitis, and you'll note here that even in the fluid-sensitive sequence at the bottom, what we're seeing is dark signal indicating adhesions and fibrous material. So I think it's clinically important for you to separate out these two varieties, Tenosynovitis and stenosing